I'm always early and always on time, and I have a sister who's always late. So I don't think it helps. So thank you for being here today. We had a survey, we had some findings, they're immediate jeopardy findings, which means we have to fix them immediately. So we only have 23 days to get this fixed. And so we have to show evidence that we did medication reconciliation training by someone outside of home health. So May is here to help us. She's one of our pharmacists from the hospital, and she does transition to care. So it's perfect, right? Because that's what we do. The other thing is we want to get this done by the 31st because we only have till January 10th to get this completed. And if they don't like what we do, it gives me some more time to fix it, right? So that's why we're on this crunch. This isn't my crunch, it's their crunch. The other thing is they have, when they were exiting, we have to do an attestation on all 576 patients that were on service the day they walked in. So that's why all of this work is timely, because it's not just going and saying, hey, we did it. They have to have proof from the patient that we did it. So I need you to bring those in. It's very important. People ask, well, why can't I scan them? Well, the scanning stuff doesn't work. We don't get it half the time. And this is not a time I want to say, oh, we don't have it. I need them brought in. There's a basket where Natasha sits. And so it's just, it's urgent. I have to say it's urgent that we get this done. So we're here today with May to help go over med reconciliation. We have found some areas of opportunity that we already identified. So one of them, Jason found in standard orders that some of the standard orders were not pulling correctly. So it would have the new dose, but then it would also have the old dose on there. And so the mesh profile was not right. If you put any kind of standard order in, you need to go back and look at your med profiles and make sure they're right. All right? Anybody who used standard orders needs to do that. If you didn't use standard orders, you don't need to worry about it.
What do you mean by standard orders?
Yeah.
We have no idea what that means.
Okay, then you're good. Yes. So if you don't know what they are, you weren't using them, we're good. We had some people that were using them and they're a problem. So,
I feel like everyone is using them, they standard order is the one that's.
okay. So let Jason, so you know what? After the meeting, Jason can help you real quick on it. I just want you, he'll know, and we have a lot to cover, so we'll table that, and Jason's the one who found it. So if you've used them, there wasn't that many. I don't think you've been used, but, okay. The other thing is, we're having.
Auto-populates, right? Yeah.
If they go to a house now and they find expired meds, that's a huge issue for us. So what you need to do is, there's bags that are in the office. You need to put down, you can say, hey, this med's expired, put it in the baggie, document that you did that. If they say, I don't want it in the baggie, then you document that you told them, and they refuse. It is all about communication. This is not our house, it's not our meds, and if they don't want us doing something, okay, but we need to document it. If we don't document it, then we're in trouble. Yes?
Oh, over the past week, I've been finding that the box says it's expired, but then they're telling me that they're putting their new meds in.
Yeah, so we had that problem already. So if they're doing that, we need to verify. I'm going to say what I said. You can tell me if I was wrong.
Okay.
I don't know what's in that bottle now, right? Because if they don't have the other bottle, I don't know what's in that bottle. So I would verify that med, and then I would call the pharmacy that they were at.
That's a good idea.
This is what I did, and if you disagree,
I would do that.
I would call the pharmacy and make sure that they just have, this is our responsibility. I know it sounds crazy, but I do not want to get an IJ for this again.
Right.
So I would call the pharmacy, ask if that's been refilled, and then I would ask the patient not to be putting their meds into those bottles. The one person, Paul is here, the patient's son liked the other bottle. Well, if they like the other bottle, when they get it refilled, ask for the other bottle, right? And so, again, we document, that's what I would do, just to verify that that med is exactly the med and that they actually had it refilled. All you have to do is document you did that, all right?
It's also like over-the-counter meds. Like Tylenol, the bottle will say it's expired, but then they said they bought a new bottle.
Yeah, then that's a problem.
Oh.
I mean, you're going to document that.
Document.
They should be putting in expired bottles to get the right bottle, okay? It's all about documentation. what the survey is going to say, hey, did your nurse or your therapist talk to you about that? And when they say no, that's a problem. If they say, oh yeah, they told me not to do that, then we're okay, all right? The other thing is, if you're getting over-the-counter vitamins and supplements, well, we got one of them for this one. So say they got 1,000 milligrams of vitamin C, I'm making all this up. And then on the med sheet it says 1,000 milligrams, but on the bottle, because they got it refilled, it now says 1,600, problem for us. So you need to watch, and we caught one, somebody caught one the other day. Yeah, Selene caught one too, and the patient didn't even know it. They just order stuff on Amazon. I do it the same thing. I got 10 different kinds of vitamins. It's whatever's cheapest, right? But for us, we need to make sure that we know the dose. So those are some of the things I want you to pay attention to. May's going to talk today. We've got a lot of stuff. There's some interactive stuff. If you could, you know, she wants to be interactive. So, but at some point she might say, okay, we got to move on, all right? Because you have a lot of things to do today.
I know you guys have a lot of questions,
Yes.
but I cleared my schedule till 11, so I'll stay after, and you can ask as many questions as you want.
And that, so, okay, thank you.
All right, ready to go? Okay, my name is May. Let me just do a short introduction of myself. I've actually been with Torrance Memorial for 22 years now. Started a long time ago. I worked in the TCU as the consultant pharmacist, and I also work in the ICU every other weekend as ICU. So I get to see both ends of the spectrum, which is very nice for me as I watch my patients progress. I also get to see a lot of med errors. And so my newer role is the transitions of care manager. That is something that it's a new role for us in general, but I've been working on transitions of care for the last few years now. I've been in charge of the Med Reconciliation Work Group, and we have representatives from the hospital, and we also have representatives from TMPN and ambulatory and their physicians. And we just have a meeting once a month, and we've been noticing that Med Reconciliation, now that we're a health system, it affects everybody in and out. And I don't see necessarily what happens with you, and I'm learning as I worked on this training with Tammy, that there are a lot of issues that we do wrong that affect you on the outside, and a lot of your med rec will affect us. So I'm here kind of to just close that gap, but also worked hard with Tammy, which is probably why she lost her voice. We worked late into the night on training for this. I want you guys, and I just want to say, first of all, and I said this to the last group too, how much I respect the work that you do. I know it's a whole, another level of compassion, I feel like, that it takes to go into somebody's home and really meet them there. It's very personal, and I know it's difficult a lot of times. So I just want to say that I have so much respect for what you guys do. I know it's not easy, and I know MedRec is not fun. so I'm trying to make this less painful for you, for everybody. I want you guys to tell me, what's your biggest barrier to MedRec? The patient? Time. And time. So time is usually what I get, same as inpatient. Sometimes we have 15, 20 minutes to do a med rec, and that's just not enough time. We need to keep coming back to things. We need to make interventions. So time is always the issue, and so we've had to really streamline what we do in a way that's very rote, and that we can get through the questions that we need to get through as fast as possible so that we can make our interventions and we can focus on what might be wrong with the med list. And so that's what we're just going to try today. We're going to go through an interview guide, which is what we teach to inpatient whenever we have a new pharmacist, a new student, a nurse come on. We've made interview guides. We started making videos for the nurses because if we go through the stepwise pattern, sometimes that part gets faster, and then we can focus on why is this completely wrong? Why are you taking this one wrong? Oh, do you know your zoning for blood sugars or hypertension? So we're going to attempt to do that. I do want to establish, right at the beginning, what happens when our med rec is wrong. So I get to see all the errors now, which is really fun when that comes in every day. So the physicians, when on the inpatient end, they very oftentimes do not wait for anyone to do a thorough history, like a nurse or a pharmacist or technician, before they start the medications. And so your list really does matter. They'll go in and they'll see the last person who kind of did a med rec. They'll maybe look at your notes and they'll say, okay, they were on this, and they'll just start everything on the patient. And unfortunately, we try to tell them to wait, but it doesn't stop them in our system in Cerner. And so we really rely heavily on what the last person does, and then we might be able to catch that and fix it later, but a lot of times that goes unnoticed. You have a question?
So they can actually see ours?
They see your notes. Your matrix care doesn't talk back to us directly, but I think someday it will. I would hope so. In this day and age, I would hope matrix care comes back to us, but they see your notes, and we rely heavily on the home health notes that go in. Yeah. So, and it's, and that's where it does matter. We do look through your notes, and I do see the extent of what you guys do. You guys do a lot. I know it's a lot in there. But we oftentimes, that's just what they go off of when the patient comes in. The technician or the nurse or the ED nurse isn't going to get to that patient in the 20 minutes and do all the med history, a thorough med history, and then the physician comes. That should be the right process, right? But it doesn't always happen. And so a common example, I'm just going to give, these are real examples that I get sent to me. So a patient came in, the med history wasn't cleaned up by anybody, but there was no anticoag on there. So the Pixaban wasn't on there. Patient has a history of AFib, but there was no anticoag. The physician started their med history as he saw it. Patient was 3 days in when they had a stroke hospital. So it was missed, and nobody realized, well, they have AFib, why aren't they on an anticoag? Was it stopped sometime? Is there a reason for that? Another example, a patient was on carbidopa, levodopa. They were on it 3 times a day and at bedtime, which is not uncommon for Parkinson's medication, right? You're on it all the time, 3 times a day at bedtime. Well, I think it was confusing that there was 2 lines. No one clarified that. The physician just started the bedtime dose, thinking, well, that maybe is the newest one. And by the end of this wasn't until the end of their stay in the hospital. They had Parkinson's symptoms again. We had to do service recovery. The family's like, what is going on? Why did we come here for one thing and now they're going away with aggravated Parkinson's symptoms? So that's a very common one too, where it needed intervention by somebody at some time, right? This was an example where gabapentin was on the initial med history. Physician, of course, just started everything. Nobody spoke to the patient. I think at this one, actually, we signed it off as a history was done. The physician thought that was the list. Well, the patient had stopped taking gabapentin 4 months ago because they had rhabdomyolysis. So they had muscle breakdown from the gabapentin, they had pain from it, and nobody took it off the med history. So we pan-started everything again. The patient started getting symptoms again. So that was one where clearly the patient couldn't even tolerate the medication anymore, and we went ahead and resumed it in the hospital. So a good med history does matter. We don't want to go and show everybody all the mistakes every day that come from it, but just know that it does come about. It comes about almost weekly. I get something on it. And so what you do does matter, and I know it takes time to do it. And so what we're going to go through today is try to script it out in a way that, boom, 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 you ask these questions, and you go through quickly what is not relevant, and you focus on what is relevant, and hopefully categorize it so that by the time you make your interventions, the physician is all clumped together. Because I know for me, when I call the physicians, I have like one chance to talk to them, if at all, right? Like they're not gonna call me back a second time. So I have to get all my ducks lined up in a row before I even call them. Next slide. All right, so a couple things. So we're gonna talk about a script. For me, I go by a few rules of thumb when I do med history. One is like, what did the physician intend for that patient to take? Like, what was their instructions to the patient, and is the patient following those instructions? So that's the important part. For you guys, you have the pill bottles in front of you. It's very important to write down exactly what was on the pill bottles, because that is what they're gonna be surveyed to, right? So if a patient says, well, the physician told me not to take it 2 times a day, the metoprolol anymore, which happens because the doctors should be writing new scripts, but they don't write new scripts because you still have a bottle of it. Well, you put down what the pill bottle says because that's what's in front of you, and then you have a comment section, and that documentation and that comment section is going to become very important. So the intention and comment section and clarification. Did the physician really tell them to stop taking it? And I will tell you, a lot of times when you clarify it, they mishear, they didn't understand correctly that they wanted them to stop taking it 2 times a day. So it's very important that's pending clarification. So what did the physician intend for them to take, and what are they doing? Do those match up? That's where you find your discrepancies, your interventions. And what will keep the patient safe? That's also just a rule of thumb. You just keep it in the back of your mind. If they're taking an expired oxycodone from a year ago or 2 years ago. Is that safe for the patient? Obviously that one, it's an obvious example, but just go by those 2 rules every time you look at the medication, and that will guide you as to what to write down and how to intervene and how dire that intervention is. Sometimes I need to call the physician like every half an hour to get them to call me back, because it's like are they supposed to be on the anticoag or not? Are they going to have a stroke or an MI or a PE before I get back to them? So, and then sometimes it's like it's an OTC medication that they decide they're going to take daily instead of what the bottle says, which is 3 times a day. I'll leave that for the physician, but I don't need to get that done that day of. So the pre-visit, I hear you guys do a pre-visit, and this is the script. Next. That's the phone call. That's the phone call. Yes, sorry. So the phone call, I scripted it out. I know this is remedial for everybody, but again, helps you can have your own verbiage, but I'm going to come to see you. Can you gather all these medications? And I'm going to say this over and over again today, that if you don't specifically, intentionally say something, they're not necessarily going to gather or tell you about it. That's what we found. We may think that an ointment is medication, but they might not think it's medication at all. So we just keep saying the same thing over again and asking the same questions about, are you on this, this, and this? And so prescriptions, over-the-counter, herbals and vitamins, topical, eye drops, ear drops, inhalers, and please make sure these are available for you to look at. You guys do pill bottle reconciliation, and I know you have to look into the pill bottles, so if they can just gather that for you. Also, something that came up in the previous class is that the research and investigating you guys do before you go into a home, we spend a lot of time. I would say most of our time is spent actually outside of the patient interview and investigating everything they were on before. I think Matrix Care pulls in. Can you guys see what they're getting at CVS?
Yeah, we can send it over.
Can it pull in what they picked up from CVS or Walgreens?
No. Nothing.
Nothing.
It's from scratch.
It's from scratch, okay.
It's only what they prescribe. We'll look at that. I'll get you more.
Okay.
We do have the capability of getting that.
Okay, that's very important, so we'll talk about that more. Cerner does, that's one of the biggest things in Cerner that has helped us, is that we can see what they picked up when. So you can see.
What they picked up recently, they just pulled up all their medication lists.
It's just a big medication list. It's just a mess of a list. Okay, got it. All right, so there's only so much you can do with a mess of a list. What we do is we map it to what they're getting externally, which is basically we can pull in what Walgreens, CVS, Costco has what they've picked up, or what prescription is waiting there for them if they haven't picked it up. Doesn't mean it's always right, because the doctor can prescribe something and you could have never picked it up. Sometimes they prescribe it wrong, like they prescribe Levaquin, like, oh, wrong patient, but it's already got sent to the pharmacy, and that's just electronic, and it pulls in too. So it's not always right, but it does help when you're taking like a Torvastatin 40 for like 3 years, and then the last pickup was a Torvastatin 80 for the last 2 months. Like we can see that, oh, you picked up an 80 milligrams, how come you're showing me a 40 milligrams? So hopefully we can get that external in to help you guys do a little bit more investigating before you go into the home, and you have a little bit more resources at your fingertips. So pre-visit, we're going to do some role playing later, but when you're going to call them over the phone, they may have some questions for you. What if the patient were to say, I don't have vitamins, but I do take a probiotic called Culturelle. I take that every day. Do I need to show you that one? Yeah, so we put probiotics on too. Counts. Almost everything counts, right? Sometimes I take Tylenol or ibuprofen for a headache. Do you guys need to see that? Yeah, you need to see that. What about I have a lot of old medications in my cabinet. I don't take those anymore. Do you need to reconcile those?
If it's not on the DC med list.
If they're not actively taking it, not necessarily, but what you can do, right, is educate to those. Old medications in the cabinet can be a danger. And we'll talk about expired medications later, but you want to educate to what you do with those old medications. So that's opportunity for education. Do they need to spill out their whole medication cabinet? I don't think so. I wouldn't pick out my whole medication cabinet for you. But, what are you supposed to do with those and that little baggie? And the opportunity there to tell them and educate and document that you educated on that, please.
One of the findings actually was the patient was on Percocet, and it was stopped on April. We weren't even in there in April. but then 2 weeks before the surveyor came, they decided to start taking it again. So that was something that was there. They weren't taken, but they decided to take it, right? So that's another issue for us, so.
Yeah. Documentation is very important. You know, we're not there to police them, right? Like if you want to start taking your old Percocet, I can't necessarily do anything about it, but we should have educated them that they shouldn't be taking their old expired medications. So now, having said that, if you were to tell me to throw away the Vigamox vial that I have that, you know, hasn't been opened and I want to keep it in case of an eye infection, I'm not going to, I'll put it in the bag maybe when you're there, but I'm not going to throw it away. I'll probably take it right out of the bag afterwards. But you've educated me on what I'm supposed to do with that, right? So, you know, education and documentation is very important. Again, they get to choose what they want to do with it, but you can tell them the dangers and the risks of keeping old medications around. We'll talk about that more. So the next slide, we talked about that. We're going to go into medication allergies. We always go through this again, and I think our patients inside the hospital get sick of us asking about medication allergies at this point because we ask about it over and over again, but it's very important. It's kind of a baseline step to medication reconciliation. Do you have any allergies? And the next question always is, oh, tell me what happens when you take that medication. So if the patient said that I have a rash when I take that antibiotic, is that considered a true allergy?
No.
A rash is an allergy. Yeah, a rash is an allergy. Yeah, so a rash is an IgE-mediated reaction, so that is an allergy. Even if it comes a little bit later, it is an allergy, so you want to put that in as an allergy. What if they told you, well, I have diarrhea, I get stomach upset when I take that antibiotic? Is that an allergy? It's a side effect. Doesn't mean that's not important. Doesn't mean that we don't put it in. And doesn't mean that we don't tell the physician about it, but it is not a true allergy, right? What about lip swelling, difficulty breathing, shortness of breath? True allergy, right away. So please update the allergies for everybody's sake. Again, there's cases in the hospital where the allergies were updated, even though the healthcare workers knew the patient had an anaphylactic reaction to an antibiotic, and the nurses didn't get to the patient in time. And so, so please update that allergy. It becomes very important and something that we could have prevented. So we always want to know that. The next slide is information gathering. Again, I know you guys know how to do this already. We just put it on the script because it should be wrote in your head that you're going to ask the same questions. Matrix care should probably guide you as to what you need to fill in. The dose, specific dose, frequency, how they take it, how often they take it, and indication I know is very important too. I know indication is you guys have some physician notes to look back on to find that indication. That might be something that you can do prior to going into, is to make sure that everything that they're taking has some kind of indication already attached to it that you can take down notes on before you talk to the patient, that you have an idea. But open-ended questions to the patient does help. Because if they think they're taking it for something, well, I have an infection, I'm taking this, and that is not even anything to do with an infection, then it's a good education step, but also a good question for the physician. Are they still supposed to be taking that medication? Because they think they're taking allopurinol for an infection, and that's for gout, right? So good open-ended questions. And then always, again, we're going back to documentation, right? Pending physician clarification are very important words for everybody. The survey can come in like right after your initial visit, in between, but if it's pending physician clarification, you're already working on it. So keep those notes in there. And then we always ask this question again on our script. Are there any prescription medications that you or your doctor have recently stopped or changed, and did the doctor tell you to stop or change it? Again, the intention of the physician. If the patient tells us that they have stopped taking a medication and the physician told them to stop taking it, they don't take it anymore, it's not even here, like sometimes that's the most we can do, right? I don't accuse the patient of lying to me. If they say they've stopped it, take it off their profile. If you do question that at all, like why would they stop taking an anticoag when they have AFib and they haven't had any bleeding, then that is a clarification. So use your judgment on that. That's where clinical judgment comes into play. Like, have you stopped taking that? No, my doctor told me to stop taking it. I can't force the truth out of them sometimes, but we can ask the physician, did you want them to stop taking it? And sometimes it's, again, miscommunication. Sometimes it's that they weren't supposed to stop taking it, and they did, or they stopped taking the wrong medication, right? So it's a good opportunity there too. I know you hear me saying like communication with the physician a lot, and I know that's a barrier also, right? Getting a hold of those providers and talking to them even at all, or their office, it takes time, and it's a pain, right? Sometimes they don't call me back, but we have to bundle everything, and then, you know, don't be afraid to call. This is part of our job. We're healthcare worker to healthcare worker. In the hospital, we have these layers of like protection. The nurse can catch the mistake. The physician can catch that intervention. I can catch it. But out there, I know it's just you guys. And you guys are just like the one barrier that's taking a look, and you have that clinical judgment to say that this could be wrong, you know, that something doesn't look right here, that there's not another person coming in to stop and say that. So it's up to you guys to make those calls, and don't be shy about calling the providers and telling them, no, I need to talk to you about this. All right, that's information gathering, and we'll leave that slide up. Oh, actually, no, we'll go to the next slide. So we're gonna stop here and do some role playing. I know, bear with me. We're gonna do a couple role playing today. So if you can't see the slide, I have it on paper here. This is just practice. I want you guys to go through the pre-visit and the information gathering, the allergies, and just ask the questions that we put on there. Let me pass it out. With the person next to you, with a partner. And just, you know, I know you guys encounter a lot of discrepancies when you do this. I'm sure it's not straightforward, but go ahead and talk to the person next to you and just ask those 3 questions. And it's in your interview guide too. All right, guys, I'm gonna bring us back in here. I know you aren't completely done yet, but I think you get the idea of what we're doing. Sorry, I know I didn't let everyone finish. But so the idea is to have the script in your head already when you call or when you go into the home. So you already know these are the questions I'm going to ask. I'm going to go down this checklist of questions. And you have the interview guide. We didn't laminate it because if you have any suggestions for changing, we can change it up. But we use it in the beginning. If you just use that interview guide, it's going to get faster. We'll save you at least a little bit of time to have this script in our head that we need to ask for. And then the surveyors can't say that we didn't ask these questions, right? That we didn't go through all these medications. So these are the medications. I know some of you guys threw in some like changes in there. Some of you threw in, I don't take it that way anymore. And that's good because that's usually what happens, right? When we go to home, nothing's always straightforward. And people like to take their medications the way they want to take their medications. So. All right, the next slide I have is, and this is going to be the next few slides, are really just very pointed questions on what the patient is taking. And again, if you don't ask them specifically, if they're taking like eye drops and ear drops and over the counters, they may not bring it out for you. So we just ask all the time, every single question, oh, do you have any of these that you are taking? So first is over-the-counter medication. And for a lot of these, it's best just to give examples. Aspirin, do you have an aspirin? Aspirin's very important to know that they're taking, right? But a lot of times it's a baby aspirin over the counter that the doctor told them to get. They may not think of it as a medication, but it can interact. You can be on dual antiplatelet therapy. They have a higher risk of bleeding. So give that as an example. Tylenol, ibuprofen, aspirin, do you take any of those regularly? Herbals, vitamins, minerals, and supplements. And we give examples. You guys can use your own examples. I put St. John's wort. For a while, everybody was taking St. John's wort. Multivitamins, you need to see those bottles, minerals, supplements, calcium, iron, potassium. And then what we're gonna add on here is just one question on CBD. Apparently, a lot of people are taking CBD lately, gummies. I didn't know that until I started asking, but Diane, the JACO consultant, said that we should add that in. So just a question, any CBD products and any cannabis products that you're taking, they should bring that out for you. If they don't want to tell you about it, you asked about it, right?
And what if they are taking cannabis products? How do we, is there already?
You have to free text. I think you have to free text that one in. There's probably nothing in there. And I don't know if they could put anything there. A lot of the minerals and supplements, They're not super FDA regulated, right? They're regulated as dietary supplements, not as medications. And so I think it would be hard for them to even build a template. You can take melatonin 0.5, and you can also take melatonin like 10 milligrams. There's not like this, usual range for things. It's very highly unregulated because there's a law that was passed that stopped them from regulating that. And so I would think a lot of them you have to just free text build it in there, unfortunately.
What if they smoke marijuana? Is that something that would go on the sheet?
I don't know if you can dose it, but I think you can put that in there.
I would put that they use,
Put it on the med sheet that they smoke marijuana?
I think it's important. I do think it interacts with a lot of things. Inhalation.
I'll get a verbiage on how we're going to get it.
It would probably be an inhalation.
We're already in California.
2 times a day, PRN. I don't know how people smoke that.
I'll give you an example on it.
Next slide.
I just have a quick question on the, how do you take it and why? On an over-the-counter bottle, do we, for example, I have a Tylenol, the bottle says take it every 6. I only take it twice a day. Do I?
Yeah.
So my question is, do I enter in the official part of the?
Yes, the bottle.
Is how the bottle
Yes.
is and how they take
Yep.
it in the comment?
Yeah, because the surveyor will hold you to that. But if they take it, and usually it's PRN, right? Something like Tylenol. I know the supplements aren't, but the Tylenol is often as needed. So that one, if they're just taking it twice a day as needed, it still fits, right? I mean, Q4, Q6
Right, it's
versus.
usually less. If
Yes.
it's over, then
Yeah.
I understand
If it's over, that's a problem, but it's usually less, and that should be in the comment section. Now, supplements sometimes they're pretty strict about like you're supposed to be taking 2 tablets 3 times a day for this, and the patient's only going to take it daily. That is a clarification, though. And now it's
The bottle.
yes, the bottle says
instructions
this.
is the official.
Right.
The comment is there,
Correct.
how they do it.
Yes.
And then what about like for over-the-counter supplements, like where it says that on the bottle it says it's 1,000 milligrams, but you gotta take 3 tablets and you're only taking 1. Do I have to
Bottle?
divide it by 3 and that's the actual tablet amount?
Explain that again. Sorry.
So there's a
Sorry. Let me listen to
on
Corey.
the front of the bottle,
Too much conversation, let Corey talk. so
on the
we
front of the
can-
bottle it says 1,000 milligrams,
Okay.
but the dosage to get the 1,000 milligrams it says 3 tablets, and they're only taking 1. So do I have to divide like 330 milligrams to 333 milligrams tablets? And
In the
they're
comment
taking 1?
section. So
How do
the
I enter it in?
so the bottle says 1,000 milligrams per tablet.
Per dose, and then the
Per-
dosage is 3 tablets,
The dose is 3 tablets to make the 1,000 milligrams.
and they're only taking 1 or 2 tablets.
I
at a
usually
time.
put 330.
Right, that's what I do.
Yeah. Yeah. Divide it up and put what they're actually taking in the comment section. Yes. Yes. But whatever is on the bottle and the instructions that you see in the instructions on the bottle goes on the actual order that you're putting in. But the comments is what they're actually taking. So 330 milligrams daily, that's what they're taking.
Dosage is 3
Yeah.
tablets, but they're only taking 2. You put 3 tablets daily, but then you only put
Yes.
1? Or
Yes,
2?
yes,
Oh.
correct. Because, and that's a little different from because that's what the surveyor is going to be like, why they're not taking the amount that the bottle says they should be taking, and why. And I know for supplements, it often does not matter. Even the physician would probably say on some of them that I don't care, but they're held to that. We're held to that still. And it needs to be, the physician at least needs to be notified, physician okay with them taking this, right? This is, I know.
I don't want to hear it.
They're not going to want to hear it, but we have to do it. So a lot of my calls to the physician, they don't want, like I have to, in my transitions of care, I have to get an indication for everything so the nurse can tell the patient when I'm giving you your amiodarone, this is for this. The physician's like, it's obvious what they're taking it for. Doesn't matter. I need it from you didn't put in your progress notes. So I need you to tell me. And I tell them like, this is something that I'm held to. The surveyor will hold us to. We need to know. And sometimes I let them know, patient says they're only taking their multivitamin daily and not 2 times a day. Is that okay? And they're saying, of course it's okay. I'm like, all right. It's just part of the package. We got to ask the physician. We have to clarify. And then that's notes there. And if you make those notes really clear in the beginning, the follow-up should be easier after that for the follow-up visits, right? We already know physicians okay with them only taking that daily, or only taking one tablet, 330 milligrams instead of the 1,000 milligrams.
I mean, it's just that it's totally inaccurate MedRec then, because it's not reflecting on the actual thing,
What they're taking, it all goes in the comment section.
Yeah.
In the hospital, it's different. In the hospital, we tend to reflect what the patient's actually taking and what the physician told them to take, right? But when we get, and this happens too, we get prescriptions in the hospital side, we get pill bottles, which are actual prescriptions, and if we were to change that to what they're actually taking, we actually discontinue what they're taking at CVS and Walgreens. So we have to do the same thing. In the comment section, we have to say, physician told them to take 25 milligrams daily instead of the metoprolol 2 times a milligrams. This was changed on this date. You know, we have to put so much into the comment section. So it's just information documentation. And if that's what they told them to do, that's what they told them to do. I wish it was a perfect system where the pill bottle changed and they got a new prescription and they picked it up and the label reflects what they're supposed to be taking.
For PRN medications and whether it's prescribed or over-the-counter Tylenol or something like that, it'll say take every 4 to 6 hours.
As needed.
As needed, so if the patient.
So she's asking over-the-counter medications like Tylenol. The instructions say every 4 to 6 hours as needed, and the patient's only taking it.
They may take it, I don't know, every 5 hours, every.
But it still falls within.
So
Sure, but does it fall within the 4 to 6 hours?
We can't put ranges though.
that's what I'm saying, so like how do we put every.
Put the minimum. Put the 4 hours because that's the minimum. If they take it every 2 hours, this is a problem.
Right.
Right now it's a problem. If they take it every 5 hours, this is a problem. It's not a problem. So always put the minimum in there if you can't put ranges.
Okay,
Yeah.
because I've seen that on
Yep.
prescribed medications as well. Sometimes they'll say Norco every 4 to 6 hours, or,
Yeah.
you know, something like that.
Or you have the option of putting the minimum, and if you're concerned, you can still put the range in the comment section. The label actually says 4 to 6 hours, right? Yeah.
Thank you.
PRNs I know, they're tricky.
So stick with what's written and take that.
Stick with what's written. Yeah, I had to ask Tammy this too, because I was like, really? You know, you put what's written and not what the physician told them to do. And I think the catch is we have to clarify what the physician told them to do. So that's what we have to do.
You can't just take the word, then you have to call, then you get a clarification, then we have an order.
Again, we're not badgering them for it, but we still have to check with the physician to make sure that is what. And you will find mistakes there too.
So I came across a medication like trazodone.
Okay, so medication, trazodone.
It said 50 milligrams, take 0.5 to or up to 1 pill. So I asked the patient, well, are you taking half a tab or are you taking a whole tab?
Right.
And he said, well, I'm taking it depending on how I feel.
Okay. So then that goes in the comment section. Yes. In the comment section. Does it still fall within what the doctor instructed them to do? So if the doctor says trazodone, you can take 0.5 tablets or 1 tablet of the 50 milligrams, you know, depending on how you feel at night, probably bedtime for trazodone, right, for sleep. And the patient says, well, I take it 0.5 or half a tablet or a tablet depending on how I feel, right? Is that following the doctor's instruction then? It is, right? So I wouldn't need a call on that. The doctor says 0.5, half a tablet or a full tablet, 25 milligrams or 50 milligrams, depending on how, you know, as needed, right?
So that's how we're completely writing it.
Yes.
How do you write that? Because we can't range it.
If you can't range it, you can put the lowest, or you can put the highest actually in terms, sorry, this one's the trazodone, right? 1 tablet, and you can put it in the notes. Yeah. You put in the comments that the instructions are take half a tablet, so labeled instructions are half a tablet, 25 milligrams, or 1 tablet, 50 milligrams, you know, up to the patient at bedtime, right? And then the patient is doing that. They're like, yeah, some days I'm taking half a tablet, and some taking, so they're following the instructions of the doctor.
What does that mean? How do I feel? Or, yeah.
Well, it's
Like
up to
how do you
him. I
feel?
mean, there is a PRN, and it is, you know, I think we just document that, because the physician has given them, the patient, the choice to take either half or 1. And if he says if I feel like I need a little more to sleep, then I'm gonna take it. That's how I would interpret it.
That's how I interpret it.
It's not for us to, now if he's gonna take 2 of them, then we got problems. Then we need to start, like he goes, oh, I can't sleep, so now I'm doubling it. That's where we get into it. But when the doctor gives them a range, that's where, where we would get in problems is if there's no comments.
Yes.
And they're saying, well, what is he taking? Well, I don't know. Well, how does he take it? I don't know. Did the nurse or therapist ever talk to you about this? No. That's the findings that are coming back to us.
Document, because I know a lot of you guys are doing it, but if it's not in there, then it wasn't done, right? That's why I always tell my technicians, well, if you didn't write it though, and you're telling me now that you asked the patient about that, then no one knows that you asked them.
Yeah, and the surveyor is going to say, they're going to say, now, did you ask it? And they're going to say no. And so that's where we start getting our medication reconciliation issues. Is when the patient says no.
I'm going to keep going, and we will save your questions, write them down. I will stay after, and we'll talk about more questions. So eye drops, ear drops, nose sprays, self-explanatory, but which eye do you put it in? That's really important. If I have eye infection in my left eye, and it doesn't say on there that left eye, and the surveyor comes and I have a blazing eye infection in my left eye, and it doesn't say that, then it's going to reflect, right? We want to know which eye you put in. What if the patient's putting in the wrong eye? It happens. So make sure that we ask exactly what, and then for a lot of these medications, we want to ask who administers it to us. So that becomes very important, I know, for injectable medications, but it's an opportunity for anything that you have to administer to the patient. Who gives it to you? Do you do it yourself? Question. Okay, next slide. Inhalers, patches, creams, and ointments. I know this is like a big one here. Do you have any inhalers? Specifically ask. Again, all these things, specifically ask the medicated patches. We don't think of those as medications, but they are medications. There's medication in there. I put two questions on here, and this is for inpatient as well, on wounds. This is a very common error that the doctors, Dr. Murthy, our wound care team has brought up to us, is the missing wound care medications. And we do tell them, like, we have to do our due diligence, but sometimes we just can't figure it out. We just can't find out, you know? If the wound care clinic is not open when I'm calling them to try to figure out what they're putting on the patient, then we have to, it takes time to figure this stuff out. So wound care, we ask, is there a doctor, treating that? Because then that doctor may have prescribed something that I don't know. A lot of times when they get treated at wound care, the patient doesn't know either. Like if I ask the patient, well, what does the doctor what did they put on you at wound clinic? They're like, I don't know. So we have to call a wound clinic and find out what they're being treated for. And this goes with a lot of medications at dialysis. We have to call and find out what it is, because it becomes very important if they're going to an infusion center and getting a chemotherapy infused. We need to know about that. That needs to be on the list. So it's unfortunate, but we have to figure it out. We have to have that concise list, because if they're getting EPOGEN at dialysis, it will affect their blood. So what if they're getting EPO and their labs start coming back at hemoglobin of 11, 11.5, 12, and they're still getting EPO? Those are interventions that the doctor needs to know about, because they can clot. They can have a blood issue when they're still giving a medication. So those are phone calls that we have to make. Medication pumps, insulins, we're going to talk about injectables later, but I do know that insulin and diabetes is a huge one for teaching. We have to see the glucometer. I think this was a finding as well. We have to see the glucometer. We have to try to figure out how to calibrate that glucometer. We have to do our due diligence there and document what you're attempting to do or trying to do. I know some of it will be straightforward and some of it won't, and I know there's more coming to that. I think you guys have zones. Tammy left this for me. You guys have zone teaching that you have to do. So there's one for diabetes, one for hypertension. There's probably more teaching education tools that you guys have. The patient has to have seen that and have been taught that. All right, next slide. Samples, that's also one that we miss a lot. Did the doctor give you any medication samples? Is it somewhere? Can you bring it out and show me? How do you take it? Do you take any medications from somebody else? So this happens too, right? You can just use my eye drop from Mexico, from out of the country. They may not be forthcoming with it, but if you ask them directly, sometimes they will and be like, my mom just gave me her eye drop to try, right?
How do we document that?
You put in the instructions. If they bring it out to show you, you put in what the instructions are, but you have to put in the comment section that this was prescribed for somebody else. Patient is taking it, will clarify with physician. Now, I think that's a good teaching moment right there, that if it was not prescribed for you, should they be taking it? they shouldn't be taking it, but their physician does need to know about that. So depending on the medication, it could be very, very important for the physician to know. But either way, we need to let them know about it. And so you see, again, I'm saying a lot of times that the physician needs to know about it. I'm bundling all that till I'm all ready to talk to the physician, because it's going to probably be a list of things that we need to tell them about. Next slide is injectable medication. We mentioned before, I know you guys have some tools already and you already have some resources to know what they're taking by injection, but we need to know who's administering that to them. That's a very important question for injections, is who's giving that to you. Next slide. So then we're going to go to investigating the medication. So this is where we're talking about expired medications and more investigation. Okay, expired and discontinued medications. We talked about the baggie system. And again, this is an area where you can't police them, you can only educate. So we're there to educate and document our education, right? So encourage the patient, if they don't want to let you touch their pill bottles, I know you're supposed to do pill bottle reconciliation. Some people are very personal about their medications and they don't want you handling them. They can handle it and do a show and tell themselves, try to offer that to them. Well, can you show me what you're doing, you know? And again, document. If they're like, I'm not even gonna show you my pill bottles, you have to document and do the best you can with that, you know, but they should be showing it to you. If they can't, I think that if they won't show you their medications at all, I do think your manager needs to be notified. So because we're held to that in home health, and so if they aren't gonna show you anything at all, I do think that's a conversation that you need to have with your manager.
I actually had a patient called to complain that the nurse kept asking for his med bottles. So I called him, I go ahead and call State. So anyway, I called him yesterday. I was laughing. But I called him yesterday. We had a very nice conversation. So he's very particular, doesn't like people touching his stuff, but we negotiated every other week. And so he's going to let us do them every other week. And he's like, okay. So, you know, sometimes we can negotiate some things, you know, and he understood, but he's very particular. He doesn't want stuff touched.
Yeah.
And so every other week. So
I can see that. I know there's a lot of people like that.
I'll negotiate. I started out with, okay, I understand, you know, what could we do to make it work for us, for both of us?
Yeah.
So.
Expired medication. So this is a tough one. I know. I think if all of us went to our cabinets, we might have something in there that we're keeping and we're holding on to. But again, you have to educate to that. If you leave medications, expired old medication in a cabinet, hang on to, I know you paid your copay for that. Could somebody else come in and take it later? If you have grandchildren, can they find that medication and take it? So you can educate to the best of your ability on what to do with those medications and put it in that baggie. Consider like throwing them away. Do safe disposal. And I know you guys have those baggies, and you guys have in your manual how to safely dispose of medications, not flushing it down the toilet, but mixing it with water. That's what the bag is there for, right? You can dump it all into the bag and mix it with coffee grounds or water and then toss it that way. But just do what you can for educating them. But if they're taking an expired medication, we have to document, you know, you instructed them not to take the expired medication, that, you know, they've been educated on it. Now, if the surveyor shows up and they're intent on taking it, you've documented what the instructions were, what the physician wanted them to do with that, right? The physician knows about it. You told them what to do. So.
What's the best education to give someone on their expired medication? Because most people think it's okay, maybe it's just not as effective, but it still works for me. What else can you convince them that please don't take it?
It's a hard one.
I mean, what can
It's a hard one, especially if it's like over-the-counter Tylenol and you don't want to go out and buy a new bottle, right? Like you just want to take your over-the-counter medication. I only take it like, you know, twice a year anyways, right? I don't want to go get a new bottle of it.
I have like an expired pain medication. I had surgery 2 years ago, and now I still have, and it still works for me. What else can you say?
Well, say you have a drug interaction with an expired medication, and the doctor finds out, well, you know, you're taking that oxycodone, but it was from 4 years ago. Which happens. We have, you know, expired narcotics in our cabinets. Now I don't know how much of that you actually did take. You know, I took like, you know, 5 of them before it worked. Well, I don't know how much of it degraded, so I can't tell how much you actually took when you came into the hospital.
Something less effective. Like I said, is there something else you could tell them and really make them think I should stop taking it, not just because it's not working?
The only thing I could think of is the possibility of somebody else getting their hands on that oxycodone. Is that, no, and then they'll say, you know, I lock it up and, you know, things like that. There's only so much you can do, but we have to tell them either way, this is what you should be doing with it. You know, and you can say it, we tell all of our patients, you know, that these medications can get into the wrong hands. They can get into a child's hands, you know. A kid can come in and they can see that bottle of pills that looks like candy, and they can take, you know, 5 of those oxycodones. So, and it hasn't not happened, so that's the best we can do. You shouldn't be taking it. It's not effective. The doctor won't even know how much you're taking when you take that medication. If something happens to you, I don't even know how much you took to drug interact, and then it could get into the wrong hands.
I have a question regarding if you walk into a patient home and they're taking a CBD product.
Mm-hmm.
What would be your take on how we should handle that with a patient? Because one, we don't know what the ingredients are to determine if there's any drug to drug interaction. So
now,
would it be best to tell the patient to hold off until we can clarify with the MD?
No, you can just list it and tell them, I'm going to clarify this with your physician. You can just list it and clarify. It's really very rare that it's, you know, that we like halt anything, right? I think stopping a medication isn't really necessarily our job. Now, some things in your clinical judgment are going to need to be clarified quickly, right? If the patient stops taking something like a blood thinner or something that they could, you know, that you need to clarify, you're going to clarify that day and tell the patient and educate the patient on restarting the medication that they decide to stop. But when it comes to CBD products and a lot of our supplements and OTCs, you're not there to tell them to stop taking something, but you're there to let their physician know about it. And it's up to the physician for you to communicate back to them what the physician said to you. Physician said, why are they taking CBD products when they're already on a narcotic, you know? They're already taking like Norco and already have prescribed for them morphine. You know, they shouldn't be taking that on top of that. And so, a lot of times the physicians understand that they are, that's fine. But if the physician says something, that's your job to communicate back to that patient that the physician wants you to stop taking this product right now. And communication, if the patient says, I'm not going to stop taking it, then they're not going to stop taking it. You know, we have to educate them. And you can tell them, you know, there's interactions. We don't, you know, it's gonna make your morphine too high of a dose when you take this, but there's only, you know, it's your job just to communicate it back. And put down, right, document that you did that.
And then I have one other question.
Yeah.
I did a med rec on a patient. Is it normal for the pharmacy to write the, discontinued date on the label? Because all of his medication had it written on it versus printed.
That is unusual. Discontinued date or expiration date?
I'm assuming that's what it was.
Well, it's usually...
It was like 1-26 or 3-20.
So that sounds like an expiration.
Right.
Yeah, so sometimes they will write the expiration on, yeah.
Okay.
Is it normal? Not really, but sometimes.
It was on all of his medication.
Yeah, sometimes they have a glitch in the computer system and they'll handwrite. Discard after, yeah. So it's a legal requirement that we put the expiration date on it, and if the computer is not doing it that day, they'll probably write it on.
Okay.
Yeah. Next slide is side effects, drug-drug interactions. I know you guys are held accountable to this too, on top of everything else that you do. Matrix care will point you out to them serious side effects. A lot of times the physician knows this already, sometimes they don't. And so if you put everything in there and it crunches out the serious side effects, this is another thing you want to add to the list to tell the physician. And it may be something that they don't care about, but it may be something that they didn't know was happening or was going on. So that's something, and side effects for the patient, if they're experiencing any side effects, again, same situation, sometimes the physician will be like, that's a common side effect of that medication. It'll go away probably in a couple of weeks, so I want the patient to keep taking it. Sometimes it's a very serious side effect that the patient's like, no, I didn't know that they were having that. Let's stop that medication for now. So part of your clarification. So the next slide is clarification to the physician. We're not going to, and you can go into the next slide, Veronica, after that. We're not going to go through this in detail because this is pretty much a summary of everything that you've already done up until this point, right? You've collected all these clarifications, the side effects, the drug-drug interactions, how the patient's taking it differently from what was on the pill bottle. And those are all the things that you're going to clarify with the provider. And just crushing of NRL2 medications, that's also something that may need to be clarified with the physician, or if you can't reach the physician, the pharmacist could probably clarify that too for you. I don't know which is easier to reach, but whoever you can reach at that point. When you call a physician, how long does it take for them to give you a response? A week.
We call that.
Crazy. Okay.
Very rare.
So you tell them I am a home health nurse or therapist, and okay. All right, so that's something that I think need to work on as best we can, give you as many tools as possible, whether someone brought up emails and faxes in the first class, anything possible for you to get that communication through, but that's why the note pending physician clarification is very important. And what I'll do on mine is I'll put clarification 3 calls made. Like I will put the number of times, because I'm so annoyed at that point that I haven't been giving a call back, and I'm trying. I'll put times, 3 calls made to the physician. I'll put 5 calls made to the physician to get that call back. And I'll emphasize, I know you guys do it, but I'll tell the office I really need to talk to this doctor about this. Sometimes there are some things the office can clarify with you without talking straight to the physician, and that's fine also. But I know sometimes you really need to just let the physician know. All right, education. The next slide, the slide after, Veronica, you can go on. So education, now this is one thing, even if you've educated the patient when you're holding their pill bottles in front of you on blood pressure, on blood glucose levels, even if you've done that education, make sure you do like a summary of it later on, because unless you tell the patient, I'm educating you on something, they don't know that you're educating them, if that makes sense. It sounds more like a conversation instead of I am actually, stopping to do education. So read back everything that you went through with the patient, do a read back with them, and tell them what you're clarifying with the physician, and then educate them, the next slides. Educate them on their glucometer again. I went through the glucometer with you, I did that education with you. I went through the zoning for your blood pressure medications. Say it again to them. Make sure that you say it again with education. Now, there's this little pill bottle dude on all the slides. This is Medication Mike, or whoever you want to name him. I think people have changed the names on the nursing units. But what we found when they did a little investigation in the hospital is that a lot of times the nurses and therapists are educating the patient, and the patient, when you ask them, they don't remember that they're being educated. In the whole process of everything that's going on an admission or a discharge, there's a lot happening, right? And they don't remember that I got educated on my medication, especially like the D parts that I see the nurses do in the hospital. There's tons of information there, and the focus might not be the medications at that point. There might just be one medication that we need to make sure that you can get picked up, right? So we have this Medication Mike pill bottle. This is a symbol on a lot of our paperwork, but it's also a pin that the nurses wear around to remind the patient that we've educated you. It's a reminder for us that we are educating, and it's a reminder to the patient that, so we actually have the nurses point this out, like, I'm going to educate you, this is medication, whoever you want to name him, and tell them, like, this is a visual reminder. And when you have a visual reminder, a picture, sometimes it works. And they went back and they re-ran the numbers, and they did an audit again, and our numbers went up when we started just this visual aid. It's just a psychological thing. To know that you're being educated. So I had pins for everybody to wear. You can name him whatever you want to name him. The nurses in TCU renamed him Medication Miguel. So rename him whatever you want to name him, and try to use it. I know it sounds like remedial, but it's another reminder, it's another picture tool that we can use. Insulin pumps or insulins, don't forget to do the glucometer checks, the zoning, and the teaching back on that, and then high blood pressure. Veronica, the next slide is high blood pressure. I think we know that there's zoning for that. How do you track your high blood pressure? Can I see the cuff that you use? Are they using it correctly? Have them show you how to use it. Next slide. Oh, safe disposal of medications. Sorry, this probably went along with the expired medications, but this should be similar to what you guys have on your nursing manual about how to safely dispose medications. So they try to make it easy. I know most places don't do like a drug take-back thing anymore. I know pharmacies used to do like this drug take-back. I don't think most do that anymore, so I think oh, they do? Okay, good. So if they're readily able to put it into that safe take-back, then that's perfect. That's where they want to put it to. That's the best place for them to bring it to, or a family member to bring it to. But otherwise, it's in the baggie with water or coffee grounds, and throw it in the garbage, not in the sewage system, not in the toilet. I think it's causing chemical levels in our water. All right, the last slide is more practice. So now, I'm sorry, now we all know how to practice. All right, guys, I'm gonna reel it back in here and give you as much time as you want to ask questions also, but can anyone tell me what discrepancies were on these?
The 7-day restriction for the oxy?
So 7-day, we see this often, right? After surgery, you prescribe oxy. How did you know it was a 7-day restriction? And how did you know it was like, it's like an old medication? Because it's not expired, so how did you know? Yeah, the dispense, but it was dispensed in November, and now we're in December, right? And so it's past 7 days. Will patients often keep taking their pain medications after that? Yeah. Because I'm going to throw away my oxycodone if I need it, right? So that's that. And then what other discrepancies have you guys found on this? Metoprolol. What's wrong with the metoprolol? It's expired, yeah. And so if it's expired, then the patient probably has a new prescription for metoprolol somewhere that they should be taking, especially if the bottle's already expired. So that's one investigation that we want to stop and ask. So that was a very simple example. I know you guys have like triple of this to look at least every time, especially with some of our patients here. Thank you for bearing with me on this presentation. I know medications are complicated. I hope, no, not at all. I hope I've convinced you that there's reasons why we overdo it and we do our due diligence and looking at those medications and the consequences of that when they come back. Medications, you know, I wish it wasn't so, but that's like our mainstay of therapy these days is prescribing medications. If it were up to me, I just have rehab take care of it all. And I hate taking medications. So, but that's not how the world is right now. Our patients are on, what do you think, what's the average of medications your patients are on now? 10, right, in the teens, we're getting into the teens. It used to be, when I started like in the long-term care, it used to be like anybody greater than 9 medications was considered like, you know, high risk. Everybody now has like 9 medications, right, if you include their OTCs. And so we're in this day and age where everyone's just stacking medications on top of medications. So we really do need to think about how that chemical is affecting them in their body. Now, I'm optimistic. I'm very optimistic that we're going to get to this point where you guys are going to be like boom, 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 and go through these things quickly that you need to go through because it's all wrote in our heads and we can do it. And then we're going to get to the point where we are just like the model of medication reconciliation. So we're going to get there. I think it can happen. It's complicated. Yes, it does take extra time to do that. But I know you guys are very efficient and you have your ways of being efficient. This is just one area that we just have to develop our efficiency in, and you'll be able to get through it very well. And it doesn't mean the surveyor is not going to find something, that's their job, but it's not going to be, we're still going to be like above average in medications. Okay, I'm going to stop. I know there's a lot of questions. Tammy was taking down some of these questions, so maybe we can make the process even faster. A lot of good suggestions on that, emails, faxes, something that we can just send over the information. Is there any other questions, like things that come up? I know we're over time, but I'm willing to stay.
So wound care medications and orders from the hospital are absent, I would say 95% of the time. Not present on discharge forms, or we don't know what to do. So we can't tell the primary, they have no idea what's going on. And then the hospital.
Is it the wound clinic they're going to?
No, just even from the hospital. So
really?
They come from the hospital, they'll have a pressure wound, they'll have a whatever, and we have to get orders.
Right.
We practice medicine.
Right.
So if wound care was included in the discharge, that would be incredible.
Like you know what I did ask? I asked Cerner if we can have a section for wound care because that is like one of the biggest misses. Yes. Cerner has not developed that section for me, but I'm going to keep asking. But that is one of the biggest misses. If they could just have because wound care is very interesting because some of it is not medications, right? It's like a dressing.
For us, it is. So we actually document. We have to document all those films and all the topicals. But
I know you have to, but in the hospital end, we're like that's a dressing. Or that's a barrier.
So it's classified differently.
It's classified differently. Sometimes it doesn't. So it's interesting because some of it doesn't even come from pharmacy. A lot of it just comes from central supply. but it's still wound care. So that's why I was like, we need a different section on wound care. Wound care is one of the biggest misses because there's no special section for it, and some people think it's medication, and some people decide it's not. And so this in-between area. And so maybe we catch one thing because it's an antibiotic ointment, but we don't catch all the others, all the dressings and all the topicals.
And then one more thing, homebound patients and medications upon discharge, a lot of them come home and they don't have the medications they were discharged with because they can't get to the pharmacy. So ambulances brought them home, and I go in there.
They haven't picked it up.
And they don't have someone until tomorrow or the next day to go get it. It's in an antibiotic.
That's a problem.
Discharge from the hospital, are you homebound? Do you have access to get this medication before you get home?
Okay.
If the answer is no, then provide it.
Can you take that down for me? That's something on my end that I can talk to the hospital about homebound medication. So that's good to know. So this is where I don't even know all the problems that you guys see.
Those are the two big ones for me.
Okay. They're not even picking up their meds.
Homebound, not getting
Yes.
access to
That's important because we've had an anticoag before. Patient couldn't pick that up. Their Brilinta, they STEMI'd, came back to the hospital again after a stent. So that's very important. Antibiotics, they can go into sepsis, right, without their antibiotic from the hospital. Any other questions that we can try to answer now or work on in the future? I hope this helps a little bit. I hope it saves you at least 5 minutes at first. And then hopefully it will get easier. And we can develop as many tools as you guys need to make it easier. Thank you guys.
All right, Diane, thank you.
Thanks, Diane.
Thank you, everyone. I appreciate it.